Okay, hi, welcome everyone. Welcome and thanks for joining us. This is Royal College of GP's masterclass webinar on physical activity. My name is Joe Besford. I'm Senior Programme Manager here at the college. And this masterclass is part of the RCGP's Physical Activity and Lifestyle project that's delivered by the RCGP and jointly funded by the RCGP and Sport England. In this webinar, we're going to learn about some of the key principles of the active practice charter, look at some practical examples of successful implementation of the active practice criteria, and think about how we can incorporate physical activity into practice. And I'm joined on mute by Dr. Callum Lees and Dr. Joe Fleming, who will introduce themselves properly in a minute and lead us through this topic. Before I hand over to Callum and Joe, I just want to run through some housekeeping and attempt to anticipate any questions that you might have at the outset. So this webinar is going to be a mixture of presenting and questions, and we're very keen to get to hear from you. It's a great opportunity to engage with some experts who've got real experience in this area. Please do use the Q&A function. If you look at where you're logged into Zoom, if you look at the bottom of the screen, there should be a Q&A button. Use this to submit a question at any point during the presentations. If it's something that the presenters can respond to at the time, they will, or if it's something that we decide to leave and pick up later on in the Q&A session that follows the presentation, then we'll do that, and that'll be a bit of a judgment call. If you want to submit your questions anonymously, then there's a button to check, so please do check that button if you want to submit anonymously. The chat function has been turned off, he says, just double checking. So please use the Q&A because it's just a lot easier for us to manage the questions, and we can get through more questions, and that means we can get to your question. We won't be responding to raised hands until the Q&A segments, and there will be time to ask a question verbally as well if you prefer to do that. By default, attendee cameras and mics have been turned off, however, so that just helps us get through the presentation. And we'll do our best to answer as many questions as possible in the allotted time. So we've got 1 hour. Just briefly, post-webinar, we are recording the webinar. So you've probably seen a notification for that. We will make a video of the webinar available on the RCGP YouTube channel afterwards. There will also be a post-webinar evaluation. I think you'll be prompted to complete that when you leave. Please do that because it helps us make these webinars much better. We've got a whole series of webinars from now until September. So the more feedback we get, the more we can tailor things to your needs. And also the question that everyone wants to know, will the slides be made available? Yes, the slides will be made available straight after the webinar. There'll be a follow-up email that goes out, a signpost you to the new toolkit, the hub, the evaluation, and it will include the slides as well. So that will all be included on that post-event email. So with all that said, I'm going to hand over now to Callum, who's going to take you through the presentation.
Thanks, Joe. Thanks for welcome and welcome everyone. Thanks for joining us on a Wednesday night. I'm Callum. I'm a GP in Highland, Perthshire, which partly explains the puffer jacket. I've just got back from work and it's absolutely Baltic in my office, so hopefully it'll come off shortly. I'm a researcher half my week with an interest in physical activity promotion in primary care, and I'm one of the co-champions for physical activity and lifestyle at the RCGP. And I previously worked at the WHO in the non-communicable diseases team there. You'll notice a bit of a change this evening. There is no Hussein, who's the other co-champion, the fairly enigmatic Hussein Al-Zubaydi. Unfortunately, he's had to pull out, but we do have an upgrade in Dr. Joe Fleming. So, Joe, do you mind just introducing yourself?
No worries, I'm off for this step in. I'm Joe Fleming. I'm the health and wellbeing coach, and I work alongside Dr. Hussein.
Great, thanks, Joe. Disclaimer, I often start with a disclaimer. I'm a pathological enthusiast by nature, and I'm aware, as you can probably see, that I'm an early career GP, and I make up for my lack of experience with enthusiasm. And so when we were planning this, I gave Joe a pretty difficult task, and I said, well, look, I want it to be interactive because I think we can all learn from each other, and I can probably learn as much from you as you can from me. So please do share, please use the Q&A, and there'll be time for live questions at the end. The objectives, a quick overview of the active practice charter, some examples of active practice charter implementation, and then hopefully a bit of time at the end to kind of brainstorm different strategies which we can incorporate. This is the first in 6 webinar series, so hopefully we can whet the appetite a little bit. When people find out what I do for research, they often ask me the same question. Well, how do we get our patients or people more active? Research has repeatedly shown the role of advocacy in primary care. In summary, active health professionals make active patients. And if there's one thing to take away from the talk, I hope it is this, that your activity levels will impact your patients. So with this in mind, and to try and warm me up a bit, can you please stand? Obviously, no one has cameras on, so you're just going to see me. But stand and join me for 30 seconds of squatting. I'm on a standing desk, so you probably see my head pop up intermittently.
Here we go. Some solidarity,
thanks, Joe.
Callum.
We're halfway through. 15 seconds left. I hope somebody is on a train somewhere doing some squats.
Yeah.
Great. Last few. Brilliant. Thanks, guys.
Real.
I've managed to ditch my jacket as well, which is always a bonus. I suspect my journey into lifestyle medicine might be similar to many of the people here in the audience. Firstly, I'm a bit of an evangelist. I've always played sport and I can testament to it in my own life. But during the pandemic, when I was working, I was struck by 2 things. Firstly, what appeared to be a growing burden of non-communicable disease. And secondly, and possibly more importantly, was that many people that came in didn't appear to have the skills or the knowledge to address it, what I now know as health literacy. And as I've developed a career and an interest, I've become aware there's a growing problem of non-communicable diseases in the UK and Europe, with now 90% of all deaths in Europe due to non-communicable disease and 84% of all disability in Europe. Female and male life expectancy at birth in the UK also lags behind other peer countries, and after many decades of gradual improvement has stagnated. The King's Fund highlighted that the UK has got one of the lowest life expectancies in the Western world. Further to that, there's the growing challenge of obesity worldwide, but particularly here in the UK, with us having one of the highest rates of obesity in the Western world, alongside the US and Canada. The cost of obesity to the NHS are huge at 6.5 billion. So I don't know if anyone has read this book by Michael Marmot. It's fairly foundational in my journey, but he starts the book with this quote: "Why treat people, then return them to the conditions that made them sick in the first place?" Or, in the words of Archbishop Desmond Tutu, there comes a point where we need to stop pulling people out of the river. We need to go upstream and find out why they're falling in. But hopefully the tide is turning. We've got a new government and health secretary that's repeatedly been talking about the importance of preventative care. And last year, the Royal College of GPs recognised lifestyle medicine in the creation of a GP with extended role framework. This talk isn't, and you haven't signed up, you're getting a comprehensive coverage of what lifestyle medicine is or isn't. But you can find out loads of information about lifestyle medicine, and particularly the GP with extended role in lifestyle medicine, on our website via this QR code, which has got loads of information and links. Give it a read and come and find, email me or give me a message on LinkedIn if you've got any questions. One of the things that people often ask about is, well, what about qualifications? What do I need to do to be a GP with an extended role in lifestyle medicine? And we specifically address that within the framework. So please go on there and have a look. But my real passion, and hence the title of the talk, is really around physical activity, or addressing physical inactivity. It's a pretty major problem. a third of the people in the UK do not meet the CMO guidelines on their own self-reported behaviour. I suspect that if it was objectively measured, it would probably be even less. A recent paper looked at the inclusion of strength training within the guidelines, which is suggested as twice a week. And with the inclusion of that, only 17% of the population meet the guidelines. Importantly, for a primary care audience, is that patients or people with long-term conditions are less likely to meet the guidelines, with about 48% meeting the guidelines compared to those without long-term conditions, which is about 69%. And a statistic that I repeatedly find shocking is that teenagers are particularly bad, with 80% of teenagers inactive and not meeting the guidelines, which is slightly higher. That's an hour a day. There's also work going on in the area at the moment, and there's loads of studies which are really kind of either supporting the need for physical activity or this one by Janney and colleagues, which was published last month from Oxford, which was actually looking at the role of physical activity referral rates in primary care in England. And I just wanted to raise it because it had a few interesting findings. First of all, people that are 65 or older are much more likely to be referred to a physical activity program than younger people. And there's quite a significant geographical difference that exists, with GPs in the northwest twice as likely to the southeast as England to refer patients to a physical activity referral scheme. And there was little variation for social economic group or sex. This is a graph from the CMO guidelines, from the UK CMO guidelines from 2019. And I think it's really of crucial importance. The big take home is that some physical activity is better than none, more is better. But if you do none, you have the most to gain for even doing just a little bit. And so we should really hopefully be using this to encourage us to promote physical activity to our patients. And bearing that in mind when we're addressing particularly things like inequalities, I think it's a challenge in all that we do. But in primary care, we're in a particularly unique position to be able to have, first of all, relationships with our patients, and then hopefully the ability to deliver tailored advice and support depending on that individual. And so we can support those that need it most a bit more. Primary care is a real key to addressing the problem of physical inactivity, particularly in populations with long-term conditions. Why? Primary care staff are influential and have wide reach. 1 in 4 people say that they would be more active if they were told to do so by a doctor or a nurse. And 72% of people with a long-term condition say the NHS is the most trusted source of physical activity advice. Research has repeatedly shown that physical activity promoted in primary care is effective. And in this paper by the WHO, they found that physical activity promotion in primary care was a best buy in an economic analysis. So how efficacious is health professional advice? This is a combination of work from Anne Gates and Thornton and colleagues. To get one patient to give up smoking, a GP needs to advise between 50 and 120 individuals. Whereas to get one patient to meet one inactive patient to meet the physical activity guidelines, the number needed to treat is 12. But it's not happening. Why? 72% of GPs didn't or don't routinely recommend physical activity to their patients. Within my research capacity, we've recently published a number of papers looking at the barriers and facilitators to promotion of physical activity in primary care, and also at the RCGP Active Practice Charter. And there's one that we've just submitted on parkrun practices. Unsurprisingly, in the literature and in what we did, there's 4 challenges that routinely present for healthcare professionals delivering physical activity promotion. First of all, a lack of time. And That comes as no surprise to anyone, I'm sure. A lack of knowledge is after that, one that hopefully we are looking to address. And as we update the toolkit and deliver seminars like this, we hope we can persuade people or empower people with the knowledge to deliver physical activity promotion. It's no surprise that people don't have the knowledge. There's been research that's shown that the average time spent teaching a medical student about physical activity across 5 or 6 years of medical school is 4.2 hours. Practitioners repeatedly cite a lack of support or a lack of resources for delivering physical activity promotion. And there's many different people and groups trying to address that. RCGP, Moving Medicine, as part of the Faculty of Sport and Exercise Medicine, We Are Undefeatable, who released an app yesterday. I'm not sure if anyone's come across that yet, but it's really it's a patient app which tailors physical activity advice to certain health conditions. So there are things happening, and hopefully we can share that, and we are doing that, some of that through the hub. And finally, a lack of finances, something much harder to address, but there is precedent with co-op points previously being given for smoking cessation advice. So the two recent papers that I recently mentioned, the one on the active practice charter, the one on parkrun practices, in both of them we highlight 3 things. First of all, the need for clear and ongoing communication to ensure widespread adoption and engagement. Second of all, initiatives need to be easy to implement. They need to minimize time. And the one thing we can't be doing is adding to the workload of primary care professionals. And finally, it's trying to get adequate resource allocation. And that's something that we'll continue to advocate for. Not only do we face a number of barriers, but delivering physical activity and lifestyle advice was harder than I originally thought. Let me tell you about one of my patients, Charlie. Charlie's not his real name, but Charlie is a joiner in his late 30s. And about 2 years ago, he first came to see me in clinic because of worsening anxiety and depression. Over a number of consultations, I found that he was misusing alcohol and cocaine, particularly at the weekends. His relationship with his partner was breaking down. He was having a poor diet, putting on weight, and not exercising despite previously playing football regularly. I think lifestyle issues like this or like these don't present in isolation, and to think that they do is reductionist. To be honest, I don't really know what the root cause of Charlie's issues were or are. I don't think I'll ever know. How do we address it in primary care? In Charlie's case, together we addressed what we felt was the lowest hanging fruit, the alcohol and the drugs. But on the back of this, I wanted to look at the evidence delivering multiple lifestyle interventions at once. A lot of the research that I'd seen talked solely about physical activity or nutrition. So after a bit of work, I published this paper, and I realized that most people here aren't going to go home and read it. So let me summarize some of the key take-homes. Or at least I hope you don't go home and read it. I hope you go for a run instead. Delivering smoking cessation on its own has been shown to be most effective. Physical activity and nutrition provide mutual uplift, therefore are more effective delivered together. And with regards to some of the other pillars, such as alcohol and sleep, more evidence is needed. The only caveat to all of that is that there really is not very much evidence, and much more is needed. But that is what seems to suggest, and hopefully in the not too foreseeable future, or in the foreseeable future even, we should have more answers to that. So despite all these challenges, I hope there's hope. And I hope that some of the work that the RCGP, the Active Practice Charter, and actually so many other amazing organizations are doing can help with that and provide some of the resources and support that's needed. The Active Practice Charter is a simple way to make an impactful change within your workplace that will demonstrate patients and staff that when you say that movement is the best medicine, you really mean it. It's free to join, it's flexible, and there's loads of simple and creative ideas to help you meet the criteria in this toolkit that we've just published online. So what are the 5 criteria? First of all, demonstrate that you have taken steps to reduce sedentary behavior in staff, reduce sedentary behavior in patients, increase physical activity in staff, increase physical activity in patients, and partner with local physical activity providers. The initiative does not have to be led by a GP partner or even a doctor. You might be a member of a non-clinical practice team who'd be best placed to lead that. And hopefully, as we discuss later, some people will have examples of different players of the MDT who've really led the initiative. So, what is the RCGP physical activity and lifestyle team that Joe, myself, Hussein, and Camilla, who's not with us tonight, have been working on? We basically are delivering a toolkit and resources which are online and published today. Check out this QR code, which will take you to those new resources. We run the Active Practice Charter. We support parkrun practice delivery. We deliver blogs and newsletter. And crucially, we're a community of practices that are trying to support each other. Because often, as one individual takes a lead in a practice, you can feel quite isolated. And so the hope is by garnering the support of others that we can together be enthused and deliver physical activity to the nation. So a lot of that, and over the last 6 months, we've been spent developing and updating the toolkit and resources. And we're super grateful to Sport England for helping that. We're also, in part of that process, alongside these 6 webinars, we're delivering a series of lifestyle-based clinics up in the northwest of England with Get Manchester Moving. And so hopefully in due course, we can share the results for that, share the resources, and make them available to a much wider network of practices. And here are some of the partners we've been working with in the last 6 months to help deliver on this project. I'm going to hand over to Joe.
Thanks very much, Callum. So I just thought I'd introduce myself first of all. I'm Joe. I'm an NHS health and wellbeing coach, and I work, as I previously mentioned, in Leamington PCN. I've been a health and wellbeing coach for just over a couple of years now. Previous to that, I worked in academia in health research, more recently in primary care. The last few years of my academic work, I worked in the primary care unit where I did a lot of work around the parkrun practice initiative when it was in its infancy. I'm also the physical activity ambassador for the UK and International Health Coaching Association, which is the professional body for health coaches, and a UK athletics leader in running fitness, and leader with Run Talk Run, which I'll talk to you a bit about in the next few moments. And outside of that, and I've done this for probably about 5-6 years now, I'm a 5K Your Way ambassador with the Move Against Cancer charity. For those of you that may not have heard of it, it's a group. They're all across the country. We have one in Leamington, but we meet on the last Saturday of every month at parkrun. And it's for anyone kind of living with or beyond cancer, for friends, family, health professionals. So if you're looking for a physical activity group for this group of people, I'd encourage you definitely to visit the 5K Your website. But my passion is definitely seeing people live life to their full potential. I love my work in academia, but I kind of wanted to be on the other side of it, and that's why I trained to be a health coach, and was fortunate to kind of land a role in such a kind of forward-thinking PCN alongside Dr. Hussein. You able to move the slide for me, Callum? Thank you very much. So I'm going to talk to you a bit about the Leamington Spa kind of model, what we do at Leamington PCN. So this is a diagram here of the patient's lifestyle journey at Leamington PCN. And obviously it's important to note, as you'll all know, obviously, that each PCN is different. It's made up of different practices and different additional roles. So obviously each PCN can decide how they kind of utilize their additional role funding. But this is the model that currently works for us in Leamington, and there may be elements that could work for you as well. So if any patient would like support with their lifestyle, then the first port of call is the lifestyle clinic. So patients can self-refer, they can be referred by a health professional, or we sometimes do population searches for particular patient groups, and then I batch text them using the Accurix, inviting them to sign up and come along. And we aim to have about 6 to 10 patients per clinic as a minimum, but we would usually book around 13 to 15 patients, knowing that there'll be some dropout before the start and during. Or if you could just go back to the previous one. Thank you. And then the patients will then attend 4 1-hour sessions. So we've got Happy Healthy Me, we've got behavior in the community, food and nutrition, and physical activity. And I'll go into a bit more detail about what each of the session entails in a bit. But then after each of the clinic, we also have a walk, talk, walk group, and patients can immediately join that after the session. So we've done our 1-hour group, and then we're like, right, there's an opportunity to be physically active right now if you would like. Whilst we don't force people to do it, we really do encourage them to come along and do the walk at that time. And then after the 4 weeks, you'll see the little arrow going off to the left-hand side there. Patients can then access one health coaching with me. They can also access social prescriber appointments at any time. And while we did offer a dietitian service, this isn't no longer an option at Leamington PCN, but I know a lot of other PCNs do have dietitians within them. And then throughout the lifestyle clinics, we also provide information about our Leamington PCN fitness club activities, which is the arrow going down to the bottom. And again, I'll go through these in a bit more detail in a bit. If you just go on to the next slide, that'd be great. So as I mentioned, there's several ways that patients can be referred. So we did actually obtain some funding, and if you're looking to set up things like this, always have a look at what funding there is in the local community, whether it be the local kind of active, Think Active, whether it be kind of county council, different areas where there might be small pots of money that might just be enough to start setting things up. But we obtained some funding and used this to produce some big stand-up posters which went in each of the practice waiting rooms with QR codes on them for patients to scan and book on. So they might just see this when they're waiting for their appointment, and they can book on. The booking form is hosted by one of the PCN practice websites. So we don't have a PCN website currently, so we do it this way. That seems to work. Patients from other practices are usually informed that it's going to take them to a different website, but they're usually okay with that. And we provide links in patient newsletters. So there's lots of ways that patients can self-refer. In terms of clinical referrals, during a consultation, if a health professional discusses lifestyle clinic with the patient and the patient is keen and happy for the referral to be made, then the health professional can fill in the form on the patient's behalf. At Leamington, we've got 2 adult social prescribers, and they regularly refer patients into the lifestyle clinic. Or if they prefer, they can refer them to me. I can have a bit of a conversation with them about how the lifestyle services can support them. And as I've previously mentioned, we also sometimes do specific populations. We target specific populations. So we found particularly that grouping together patients with the same condition can help make the groups clinics a bit more engaging. So we've currently run quite a few clinics for patients with hypertension. So can do searches, like our coordinator will do searches across the practices, identifying those patients, and I can contact them specifically. And we've more recently done a work well group, which is for patients who are off work sick with depression or anxiety. And obviously there's certain slow-mo codes that you can be used to code the various actions that you've made, so you can see the different ones there, depending on what it is that you've offered the patient, whether it just be advice during the consultation, whether you've given them a leaflet, referred them to a walking or running group. We have a swim group, signposting to parkrun, and obviously you've got your group lifestyle clinic and individual lifestyle appointments as well. So they're the different codes that you would use. So as mentioned, the lifestyle clinic is made up of 4 1-hour sessions. So while we present using slides and there is a loose structure to the lifestyle clinic, we do predominantly make it very interactive, giving the patients the opportunity to reflect on things, discuss topics that are important to them, and learn from each other within a group, which is really, really important. So the first one, session one, is called Happy Healthy Me. So we talk about, what does being happy and healthy mean to you? What kind of things make you smile? Because often patients might come with a lot of negative kind of thoughts about their life, but we try to make them, have some gratitude towards the things small things in life that might make them smile right now. And then we have a bit of a reflection on where they are now compared to where they would like to be. And it's really just getting them to take a step back from everything, have that 1 hour where, usually they might not be thinking about their health, but giving them that opportunity to look at the different areas of wellness and think where they might currently be feeling strong, areas that they would like to improve. And it kind of sets the scene ready for the next 3 sessions. Then session 2 is on behaviour and community and hurdle. So we talk predominantly about what is behaviour, why is it so hard to change behaviours, how can we go about doing it. Again, lots of group discussion and reflection on things that people have tried that work, things that haven't. And then we finish the session by setting a smart goal at the end that they can try and go away and do in that coming week. Then session 3 is on food and nutrition. So we really focus on how we can use food to create health rather than thinking about all the things that, they can't eat or things that they need to cut out of their diet. So with that understanding that eating well in the world that we live in is really hard, and equipping people with the knowledge that they can navigate their way through it. And then finally, session 4 is on physical activity. So we talk about the different kinds of physical activity, the CMO guidelines, how much do we need, what we should be doing, why it's important, and how we can really get physical activity back into our lives. So we also have a Leamington PCN fitness club. So we've really taken that kind of a community approach to getting people back into physical activity. So as well as having that theme throughout the lifestyle clinic of telling people how important physical activity is, we also want to try and provide some of those opportunities for patients to do that. So as I mentioned, we had the Monday evening walk, talk, walk. So after each of our lifestyle clinics, we have one on a Monday, which is a practice in North Leamington, and we have one on a Thursday morning in South Leamington. So the important thing about that is North Leamington has got South Leamington has got higher levels of deprivation. So we want to be able to have 2 different groups in 2 different parts of the town that patients go along to. One of them is in the evening for people who perhaps prefer that, and one of them is during the morning time. And the reason we put the walking group immediately after the lifestyle clinic is so that people who might need to be more physically active, it's right there, they're already in place, and we can offer that walk. And then obviously after they've completed the lifestyle clinic, they can keep coming to the walk for as long as they like. And likewise, people can just come along to the walk without having been to the lifestyle clinic. So it kind of gives people that opportunity to join a couple of different groups. We also have a run, talk, run group, which runs on a Monday evening. And we normally run about 5 kilometers at a nice, easy pace. But with that, we were finding that sometimes it was great, and that people were coming along, they were running 5K, then they join a local club, which was fantastic, but then our group would get quite small again. So we thought about how we could maybe encourage some of the people in the walking group to take up running, or other patients who might like that. So we developed a couch to 5K group, which we've called Practice to Parkrun. And we follow the 9-week NHS couch to 5K program, and we invite patients to do session 1 with us on a Monday. They then, with the new group that we're about to start next Monday, they can then do session 2 each week with another run, talk, run group in their local area. Then they do session 3 on their own, and then at the end of the 9 weeks, we all do Leamington Park Run together. And we're just about to start our 4th group Catch a 5K, and they've been absolutely brilliant in just getting people together and introducing them to park run and getting running and physical activity back into their lives. So that's been a big success. We also have it's not on the list here, but we also have a buggy walking group on a Monday morning as well for patients with new babies or children up to the age of around 3. So we go along and have a walk every Monday morning. And then Swim Together is another group that we started about a year and a half ago. It originally came through from Mental Health Swims. If any of you have heard of Mental Health Swims, Everyone Active and Swim England. So Mental Health Swims traditionally do open water dips, but they really wanted to introduce a Swim Together group indoors, so people who maybe felt a little bit worried about outdoor swimming. So when it first started, they were bi-monthly, so we'd have one on a Monday evening, one on a Friday afternoon. Patients would come in, and either myself or Hussein would get in the water with them. We just have a bit of a swim, a bit of a chat, and it's a really good way of getting people back into a physical activity that maybe isn't walking or running, because that's not for everyone, but for a lot of people, swimming was something which felt a little bit more achievable. So that's now progressed in that Everyone Active have taken more ownership of it, and I refer the patients in, but they can now go twice a week, every week for 3 months at no cost to themselves. So we've really tried to get swimming as to be kind of more of a habit, which is a great development there as well. And finally, obviously, we promote parkrun to all of our patients too. In terms of outcomes, so we are in the process of collecting more data, and these will be analysed in the near future. We currently, before every lifestyle clinic, we collect pre and post lifestyle clinic data on BMI, on blood pressure, on mental health, and also overall health scores. But I haven't analysed those yet, but we do have some data from 2021 to 22. So some data based on 142 patients who attended the lifestyle clinic at the Clarendon Lodge, North Leamington Lifestyle Clinic at that time. And you can see the confidence to make lifestyle changes, as well as noticing positive impacts on both physical and mental health, all increased on completion of the lifestyle clinic. So that's really, really good. And you can see on the next slide, we've got some lovely quotes from patients that can be seen here. That I won't read them all out, but there's the one in the bottom right-hand corner here. So this person here, they've got, I've now joined a gym and go 3 times a week. We eat a lot less meat and processed foods. I cook from scratch more. This clinic has been life-changing for me, and even enabled to get engaged with talking therapy. And this particular patient, I think it was one of those things where she'd tried lots of different things in terms of physical activity. She hadn't quite found the thing that she wanted, but through kind of exploring things and talking in the lifestyle clinic, there was a particular type of gym that she really liked, and that got her really engaged. And it was because of that, then she started seeing changes in how she looked and how she felt, and it kind of snowballed from there in terms of healthy eating and things like that. So often there's just things within the lifestyle clinic that can just touch on one area of someone's life and kind of snowball into other areas and have really positive effects. We have also recently had an evaluation from Coventry University. So Think Active, our local active partnership, had some funding to allow other PCNs in the local area to also start lifestyle clinics using this model. And about 4 or 5 different PCNs did take that up last year. And Coventry University did a service evaluation, and the results of that are now available, and they are really positive, and the university are now looking to try and get funding to do a bigger study. And there is actually an event on the 31st of March in Coventry where Think Active will be presenting the findings of that that service evaluation. So if anyone is interested at all in coming along to that, then I know there's links on LinkedIn on Dr. Hussein's page, but I can also make those available after the event.
Thanks, Joe.
No
It's
worries.
amazing what you guys are doing in Leamington Spa, and it's significant for us because that's the model that we're piloting as part of the physical activity and lifestyle project that's Sporting England Fund in the Northwest at the moment. So yeah, hopefully we'll have more outcomes on that coming up. We're aware that not one size fits all. Demographics or geography might just be a few of the challenges. For example, in Scotland, there's no R's funding or no R's roles. And so I've personally been involved in establishing a local charity that we call Healthiest Town. It's a bit tongue-in-cheek and slightly grandiose, but it was done with the hope of trying to create a race to the top with some of the other local towns and villages around us. And really, it was created to try and create a community approach to health and well-being. And 4 years in, we now have 3 part-time employees. And I was just briefly gonna show you some of the things that we're doing, and hopefully just to offer an alternative to what Joe and Hussein are doing, and hopefully we can together inspire. In the interest of time, just going to skip through that video, but just a few of the physical activity initiatives that we have going is we have funding for a health coach. So Sheila works in the practice. She's employed by the charity, but works in the practice and delivers physical activity coaching to patients who can either self-refer or be referred by clinicians, or similar to the Leamington Spa model, also by social prescribers. We have a number of events and outreach events. We've got a series of winter boost activities where we're trying to introduce people to different things like yoga, cycling, Pilates. But we also, for the last few years, have hosted an annual ceilidh. It's something I particularly enjoy. For those of you that don't know, it's Scottish country dancing. And if you've ever been to a ceilidh, they're usually quite raucous, and you've got no idea that you're doing any form of physical activity because you're just having such a good time. So it's kind of a really nice way of reframing the narrative around what physical activity is or can be, and I think dance is a really important part of that. We've got a network of walking and running groups. And similar to Leamington Spa, inspired by what Joe and Hussein are doing, we set up some walk, talk, walk and run, talk, run groups out of the practice on a Monday night. And I know there was a question in the chat I was just reading, and that is Run, Talk, Run are a charity. They're now being taken over by a bigger charity called Sport in Mind. They provide all the governance and all the training and all the support. I do it in the capacity as a local GP, but I'm very conscious and during the walks I feel like I'm just doing this as a local that lives here and as a citizen. But it's great because governance and indemnity is covered. And then we're also been involved in establishing a local parkrun. It's not going yet, but hopefully it will do very soon. And we're a parkrun practice, so we're paired with another parkrun, but it's about 30 to 40 minutes away. So it's obviously it's not that accessible for everyone. We're also involved in a few other activities every year, or actually last year was the inaugural, but we've got another one this year. We had an open gate festival, which was all the local food producers opened their doors and their gates for the members of the public to walk around and see how their food was being made. And it was complemented by talks in the evenings and at lunchtime in the local town across a variety of different sites. And so we ended up having 29 events over 7 days. And it was really successful. And it was particularly the schools engaged in that quite heavily. And what's been really great is subsequently we were quite engaged with a lot of the local primary schools, and a couple of them have ditched prefects in the final year of primary school, and instead of that they have pillar leads. So we have 4 pillars: so move more, eat well, find balance and live in community. So each of those pillars has now got two kind of primary school pupils in their final year as their advocates. And we're famous for our kind of outdoor pursuits, whether it's kayaking, rock climbing, hill walking. And so one of the local outdoor activity centres provided free activities for people struggling with mental health in the winter. That's just a bit of a taster. I'm sure that people listening are doing other things, and we would really love to hear from you to share your experiences and kind of use the last 50 minutes to answer some questions, get some feedback, and hopefully inspire each other to kind of take something back and you look to implement things in our practice. So yeah, have a think about what you're doing, what you could do. If you've got any kind of ideas or thoughts on the back of this talk, then please put them in the chat, or hopefully there'll be an opportunity for you to unmute. The key messages: firstly, healthy health professionals make healthy patients. There's a strong need to incorporate physical activity in primary care, and the Active Practice Charter is a way of doing that that's simple and rewarding. There's many ways to achieve the active practice status. Joe presented one. I've talked a bit about what we've done, but there's many others out there, and we could have asked lots of practices to present. So the options are endless. We have a new toolkit and physical activity hub, which is all hosted on the RCGP website. And so what Joe mentioned, he was going to send out a link afterwards, so please do check that. And finally, evaluation and planning is key, and we're hopefully here to be able to support you in doing that. Thanks for listening, and yeah, we're happy to take any questions.
Great, thanks, Callum. Thanks, Joe. That was fab. We have been receiving questions and responding to them in chat. There was a raised hand that has now disappeared, but it's worth saying that if you want to ask a question, raise your hand and I'll send you a message to ask you to unmute and you can ask it live. Or if you prefer not to do that, if you prefer to submit a question, a written question via the Q&A button, please do that. I think that we've got a few questions that we can start with, however. Joe, is there something that you'd like to pick out there?
I've just been replying to some in the, I've been typing in, just having a look at some of the ones that I haven't answered yet.
Sam has got quite an interesting one, I thought.
Look, Sam. Okay, so you're trying to engage with the practices in the first place, I presume. Yeah, so I mean it's I guess it's a tricky one. It depends how engaged those practices are at kind of collaborating with you. I know we've actively gone out and tried to collaborate with physical activity providers. But going the other way around, it can be quite tricky to get into practice and find someone who's interested in making those collaborations, isn't it?
Sam, oh, sorry, Joe.
Yeah, go.
Yeah, I was going to totally agree, and I think a lot of it is finding the right person at the right time, and you know it's just you just need one person within the practice to kind of pick up the mantle, and that's you're in. Yeah. And I know up here in Scotland that if you want to find a primary care professional or a GP, the place to do it is Saturday morning at parkrun, because so many of them do it.
And often sometimes it's like that you say about there being a variety of local free activities that are not reaching the right audience. Sometimes it's not so much the activity, but it's the barriers that might be in the way for a patient getting there. So we got some funding to set up a physical activity menu where we linked up with local physical activity providers to then give free sessions to patients. And even kind of the fact that it was free didn't always get the patient there. So I think it's about understanding what it is that what some of the barriers are, and that might, if you can get in touch with the health coaches at the GP practice, if there are some, and then work with them and working out what some of those things are that might help patients get there in the first place, because it might be lots of other barriers other than just cost.
Right. Conscious of time, we've got about 8 minutes. So I think we've got quite a few questions, and maybe we can kind of rapid fire through some of these.
Mhm.
So I'm going to go out of order slightly. So sorry if you submit the question and I've jumped over. I just think we can probably answer some of these questions for the benefit of all. So M asks, how do we access funds for projects and local initiatives? Is there a website to find different funding streams? I mean, I can say that we've got guidance and information in the new toolkit on this. So there isn't an easy, straightforward answer, but there's guidance there to answer that question. So I would urge you to look at the toolkit once you get your email after this meeting. I don't know if you guys have anything to add to that.
Yeah, I totally agree with you, Joe. Check out the toolkit. I think the next webinar is on funding.
Great plug.
So yeah, come along. The other thing is there's there's R's roles. There is funding opportunities available, and I know that Hussein will talk about that and know more about the kind of the English stuff than I do. The other thing that is worth exploring is the extended hours. There's funding, particularly in Scotland. I think the same in England, for opening the practice in extended hours, and lifestyle clinics that are beyond our normal hours can be funded. So make sure you have a usual booking system like on EMIS, so you can prove that that you're delivering a service and you're booking in patients, and that's another way of getting some funding into the practice to deliver these things.
Guys, if there's a question that you would really like to answer, then do jump in. But I'm going to just keep throwing stuff at you if that's okay.
For the funding one, I was just going to say also with each, it's worth looking in your local area of what there is, because Sport England, if you're looking for something for physical activity, Sport England sometimes have funds, but your local active partnerships sometimes give out funding. County councils have physical activity and sport funds, so it's worth having just a search around.
Right.
Joe, there's a couple here. Anonymous attendee, observations that weren't anticipated in terms of outcomes of active practices. Yeah, I think the parkrun and active practice charter, two outcomes that weren't necessarily anticipated but came up again and again, were the impact on staff morale and kind of well-being. So yeah, I think that was a really interesting. And the other thing was engagement with the community. So there are two outcomes I didn't really expect. Charlotte asked a little bit about lifestyle qualifications. There's quite a few out there. That there's a diploma in exercise medicine by FSEM, which is great. There's Hussein, I know, runs a few Red Whale courses, but actually on lifestyle medicine, which are good. And then the place that I often go to is the British Society of Lifestyle Medicine. They've got loads of different tutorials that they run online, and they've got a diploma as well. So there'd be three I'd kind of throw out there. Sorry, I'm picking them off. Natalie, that is a really interesting question about whether other countries have tried similar programs. I'm actually missing the next webinar because I've been given a fellowship to travel to Australia, New Zealand, Finland, and the Netherlands to find out if those countries have similar programs in primary care. So I'll have a much better answer for you in 6 weeks' time. Joe, are there any there that you want to answer?
Yeah, there's one at the bottom there. Curious about health coaches. What is their scope limitations and how does someone look for them? So a health coach, we're not experts in any particular field. So a patient can come with us with all kinds of medical conditions. We don't have to know anything about that. We're not allowed to give any advice or we can't tell patients what to do effectively. What our role is to kind of have a facilitated conversation with the patient. So in essence, they have the answers within them, and it's working with them to work out what the best way forward is for them. So yeah, we don't tell patients what to do. We walk alongside them and help them make those lifestyle changes. In terms of finding them, I mean, the in England, the primary care can now employ health and wellbeing coaches as part of the additional roles, and many PCNs now have one, two, three health coaches. So, if I don't know where you work, but it's worth kind of having a look to see whether you do have health and wellbeing coaches already within your PCN, and if not, then is there a way of getting one in?
Meyer, you asked about Wales. There's some great resources from Wales. There's the Motivate to Move resource that the Welsh government produced on physical activity promotion, which I'd recommend. That was great. And actually, Public Health Wales are really engaged in kind of lifestyle medicine and preventative agenda. So there are stuff going on in Wales that the exact details I'm a bit shaky on. But drop me an email because I can put you in touch with Dr. Sarah Tamplin, who is a GP over there and does lots of work in Wales. So we'll no doubt have her finger on the pulse. Linda asked about reducing sedentary time in desk-based roles. I think it's really tricky. A lot of the evidence is more around physical activity. Joe, you might be able to talk about this. There is a growing evidence base around sedentary behavior, but standing desks, that's probably the big thing that we do in our practice. And I kind of, beyond that, we don't do loads, but hopefully standing desks in them, maybe you can even pop on next time and ask Hussein for advice on how to get funding for your standing desks. Time for any more, Joe?
I think we've got about 2 more minutes, maybe
Right.
3 more minutes. Yeah.
Andrew Power, thank you. That's he's made a good comment about active partnerships. Look up your local community foundation who hold and offer grant funding at a very local level. Great advice. Thanks, Andrew. Joe, are you picking out any there?
I see Linda's written something about how do we encourage GPs to prescribe health walks. There are many schemes over the country. I think often it's GPs knowing that these things are available, isn't it? So we've got the walk talk walk, a couple of them across our PCN. We try and spread the word as much as we can, but these things do often take a little bit of time to kind of gain momentum. Like the walk talk walk that we had in South Leamington, it was just me and one other man for about 3-4 months, but just keep at it and keep promoting it as much as possible. And once it grows, it will start to grow and it will flourish, but it just takes a little bit of time.
I had a similar experience. I took about 9 months for there to be regular attendance at Run Talk Run, and now even in the winter things can dip off and we can have 2 or 3. But yeah, perseverance is key. Yeah.
I think we are going to have to bring it to a close there. Natalie asked, would you be okay to share email address? Natalie, best thing to do is respond to the active practice email that I'll send out after this meeting, and I can connect you. And that's probably the easiest thing to do there. So thank you everyone for joining. I'm just going to sum up a little bit. So in terms of our key messages, I think the clear message is healthy professionals make healthy patients. And that there's a strong need to incorporate physical activity into primary care, which is what we're all about. So signing up to the Active Practice Charter is simpler and more rewarding. We understand that general practice is not homogenous and that there are different ways to achieve this, and it's designed with that in mind. The toolkit and the Physical Activity Hub contains lots of resources to support you on the journey and to answer these questions and more. So please do look at that. That's a brand new resource that's gone live today. And evaluation is key. And we've also got lots of resources online that we've introduced that will help practices support that in a variety of different ways. Really interesting stuff. So in terms of your takeaways from this, I would love it if you would go to the Active Practice Hub, have a look at that hub. It's been updated, look at the toolkit and share that with your colleagues. I think that's the crucial thing really, is to spread the word. We've got more masterclass webinars. Callum mentioned this is the first of 6 and we're running through to, I think, September 2025. So do look at the hub. That's got links to all of the upcoming webinars. They are based around active physical activity, but they're in different topics. So there's something for everyone there. And please do complete the webinar evaluation. when you log off, because that will really help us improve the content of these events and make sure that it's tailored to your needs, for people working in primary care and trying to increase physical activity. I want to just wrap up by saying thank you to Callum and to Joe for being brilliant, for their time, their expertise, sharing their story, for covering such a broad topic in such a short space of time. And hopefully it's given everyone a taste of the opportunities that are out there to help staff and patients. And thank you to the audience. Thanks for great Q&A, great questions. Please join us again in the future. Share with your colleagues, and we hope to see you next time. So goodbye for now, and have a good evening.